then put on the CT6. So for those of you who understand the mechanisms of both, right, what they're saying is that you'll probably die quicker from a pelvic fracture than you went from a femur, so they want you to stabilize the pelvis first before the femur. Only for those systems that use it, but I'm teaching it generic, but also to keep in mind, we're wearing green, we're SAS, we can't use it in SAS. Sorry, gotta run across the room. All right, so what helps me understand how to use these devices is I gotta get an appreciation of the anatomy. I wanna know what am I dealing with in the thigh portion of the human being. So we've got a femur bone, which is the it's the strongest long bone in the human being, right? It is the strongest. That means that's the bone that takes the most amount of force to break it. So it's a very strong bone. So why do we have very strong femur bones? What does it have to support? Right, the torso, the rest of the body. So of course, it was designed to be strong. Also, because we walk around upright, right, we need muscles to help support that femur bone to keep us upright. So we've got a group of muscles in the front of our thighs, the quadriceps femoris. We've got the hamstring muscles, which is in the back. And then you have the adductor muscles, which is on the inside of the thigh. The combination of all, so that's 4 in the front, 4 in the back, and 3 on the side. I mean, what are we talking about? 11 separate muscles just to support one thigh, right? That's a lot of muscles. And we'll see why, and I'll actually show you why this comes into play and why we have to use a traction splint, okay? Also, in the thigh, we have nerves, arteries, and veins, right? So nerves communicate with the furthest part of our body to the spinal column and then to our brain. Arteries and veins is the pathway in which circulation travels, right, to the body and then back to the heart, okay? Okay, so, let me do this because it's probably better imaging. Can you see this better? Okay, so on the left, I've given you a fractured femur mid-shaft, right? That's basically the neighborhood we're going to be working in when we're using the CT6. On the right, like I said, I like to see things. I'm a visual learner. I like to see what's happening underneath, right? So you see the fracture on your right-hand side, but I can also see lots of arteries and veins. So if you have a fracture, now this is a non-displaced fracture. That means the bone is broken, but it's still staying aligned, okay? A displaced fracture looks like this. When you have a displaced fracture, the bone ends are very sharp. They will cut through nerves, arteries, veins, and muscle, okay? All right, let me show you another one. Okay, the image on the left is the nerves. The biggest nerve is the femoral nerve. The biggest artery and vein in the previous one is the femoral artery and the femoral vein, respectively. Okay? So you can see all around the femur bone, there's lots of nerves, arteries, and veins. Okay? That's because that's the way we're made. I want you to appreciate that because there's things that we need to do to evaluate the patient. And when you ask yourself, or when you ask us, why do we have to do this? I will refer back to here and say to you, this is the reason why, okay? So on the image on the right, so this is an anterior image. You're looking at front, so you have the quadriceps femoris in the front. That's right here. And then on the side, you have the adductor muscles, and then the hamstring muscles are behind. I don't have an image of that, okay? Everybody happy? Okay, so what are the therapeutic effects of using a CT6 traction splint? First, it promotes hemorrhage control because if an artery or vein is lacerated and it's displaced, by applying traction brings it closer together, okay? And also, the traction doesn't allow the bones to be moving freely, and that's how it cuts arteries, veins, nerves, and muscle. Analgesia. Once you have seen the relief on someone's face after you've applied traction to their broken femur, you will never forget it. It's like night to day, okay? Bless you. Okay, it reduces muscle spasms because when the femur bone is broken and the distance is reduced, the muscles go into spasm. Okay? So by pulling traction and bringing the muscle length back to its normal length, it stops the spasms. And it prevents further damage, again, because when the bone is not aligned and it's displaced, it will be cutting nerves, arteries, and veins, and muscles. And if it's not held in position, if it's just left there to flop around, it will cut those respective parts of the anatomy. So what the traction does is it pulls on the two ends of the broken bone and locks it into position so that it can't do any more damage. Contraindications. So this device is not for every person that has an injury to their leg or to their thigh. Someone may have a mid-shaft femur fracture, but if they have injury to their knee, you can't use it. If they have injury to their ankle or their foot, you can't use it because the orthopedists don't want you to pull on the knee and pull on the ankle. The problem with the CT6 with regards to anchoring is that the reason SAS doesn't like it to be used in the pelvic fracture is because the ischial strap goes over the ischium bone. So if you have a pelvis fracture, SAS says, no, we don't want you to use it that way. That's part of the problem. If you have a foot injury, you actually have an ankle and foot strap on the CT6, which helps pull the femur apart to line it up. So they don't want you to use it for that reason. So if you have a foot injury, ankle injury, or a knee injury, even though they have a femur fracture, you can't use it. If they have a neck of femur fracture, which is all the way up on top of the femur next to the pelvis where it actually sockets into the pelvis, if you have a fracture there, they don't want you to, because the orthopedist doesn't want you to pull. They want you to leave it in that position. Okay, so that's, for that problem, the CT6 won't work for that. It'll make the problem worse, and the pelvic fracture we just talked about. So let's move on. A new word, kinematics. So kinematics in pre-hospital emergency medicine is the science of studying the physics of trauma. Like when a car hits you, what happens to your body? The force from the car, when it hits you, what are the forces? When you get thrown across the street, what happens to the front of your body? What happens to the back of your body when you hit the ground? That's what kinematics is about, okay? So, keeping that in mind, we are looking at the femur. We know that the femur is the largest and strongest long bone in the human body, right? It is so hard to break that it takes 4,000 newtons of force to break an adult, healthy femur bone, okay? So what does that mean? Okay, so if I sat on this chair and put my leg across here, under my knee, and I got David to get a long sledgehammer, and he swung over his head and hit my femur, okay? That's only 3,000 newtons of force. It won't even break it. You need more than that in order to break the femur. Just to give you some idea as to how much force is required to break it. Why we need to know that is because if a patient has a fractured femur, they were exposed to a lot of force. And if they were exposed to a lot of force, you really have to ask yourself, as a practitioner, you have to ask yourself, are there any other injuries? Because the femur is connected to the pelvis, is connected to the spine, is connected to me. So if a huge amount of force broke my femur, there might be a very good possibility that I have other injuries, okay? So for that reason, if it's a result of a very serious trauma, you may want to consider complete spinal immobilization. There may be enough evidence for you to do that. Okay, clinical management. So in the process of applying this device, one of the things that we want to do is we want initially to have manual stabilization. So if we're working as pairs, and we'll demonstrate that for you, one of us will hold the leg in position so that it doesn't move while we are applying the traction, okay? Because even in applying the traction, you're moving, and believe me, the patient will scream because it's very painful. Okay, the other thing we need to do is we have to expose the limb. That means scissors, cut the leg off. Sorry, cut the pant leg off. All right, you see that was a test to see if you were asleep? You weren't asleep, congratulations. All right, that was a good cleanup, huh? Okay, so you need to expose the limb. Then we also have a responsibility to assess the injury. The first thing we'll see is it a closed femur fracture or an open one, okay? So a closed one is just like a huge swelling, and the foot is probably shortened, then one leg is shorter than the next, you know, that those are supporting signs that's telling you that that's happened, along with an associated mechanism of injury. The next is symmetry, right? So one leg was probably shorter than the other. That's symmetry. Symmetry means comparing a good side to the bad side, right? Of course, it becomes a problem when you have a bilateral femur fracture, because they're both going to be shorter, and you're going to have swelling on both, or they may be open. Okay, now, the other thing that we're responsible to do is to assess distal, furthest away from the core, and that basically means your foot. You need to assess perfusion, motor, and sensory. So how do we assess perfusion? Anybody?
So you press down
Nail bed refill.
on the toe.
On the toe. That's one way of doing it. Very good. What's another way?
Pulse.
Checking the pulse. Checking the dorsalis pedis pulse, right? Because remember, we just saw images where if the fracture is bad enough, it will cut through arteries and veins. And if you cut the circulation off, you will see it. You will see that the leg will become pale, white, cold. You won't feel any pulses in the foot. Okay? So that's vascular. How about neurological? Suppose we cut a nerve, all right? How do we assess for that? Somebody else besides Kelly? Because I think she knows.
Wiggle the toe.
Wiggle your toes. Okay, so what's that assessing? Motor or sensory? Motor. What else? We've done perfusion, we've done motor. What's sensory? That's it. So you touch their toes and you ask them, which toe are you touching? Okay? So if there's no damage to the nerves, arteries, or veins, the patient should be able to do all that, right? For you. Okay? So we'll be demonstrating that. Okay, so the result of your assessment will lead you to two possible places. The first is a simple fractured femur. That means there is no neurovascular compromise. It's just a broken bone. It's perhaps non-displaced, right? It's just broken, it's just there. Okay? The other one is the one you begin to perspire over. Okay? Because this is the broken bone, and you go to feel a pulse, and there's no pulse. The foot is cold. You ask the patient to wiggle their toes, they can't move their toes. You ask the patient, you know, you're touching their fifth toe, their little pinky toe, and you say, what toe am I touching? And they say, you're touching my foot? Right? That's bad news. Okay? This is a complex orthopedic emergency. The first case, the simple fractured femur, is 8 to 10 weeks, they're up and walking around again. A complex orthopedic emergency is a limb-threatening emergency. Okay? So if that's not able to be fixed surgically, we're talking amputation. Okay? So it's two different emergencies, right? Same ball game. All right. So the clinical goal with regards to traction, and the two things we're looking for when we apply traction. First is pain relief. Okay? The patient goes from to like, okay? And that's from the traction. That's not from the blue whistle, the fentanyl, or the morphine, right? That's just from the traction. Of course, we will use the other stuff, right? In fact, we might use it early, right? Might want to give them the blue whistle because they're going to be moaning and groaning. And then we'll do the traction. And, and the last thing that they want us to do is that when you have the fracture, the leg is going to end up shorter than the other. When you apply the traction, and a measure of completing the traction is that the injured leg is about the same length as the uninjured leg. Okay, and with the pain relief, then you're successful. You've done your job, and the patient is basically packaged to go to the hospital from that point. Okay, so on the left is a diagram of an open femur fracture. On the right is a real open femur fracture. So what I want you to look at is, don't have a pointer. Okay, so here's the end of the femur, and there's the kneecap, right? So you see all,
Oh, it's a touch screen.
Don't touch.
Don't touch the screen.
Don't touch it. Thank you.
Sorry.
It's all right. I'm learning too. Okay, don't touch it, right? Okay, so you see where the end of the femur is, and you see where the kneecap is. So this is actually a mid-shaft fracture. But what's happened is the muscles, the quadriceps femoris, the abductor muscles, began to contract and push the bone further down and further out. So when you apply traction, what will happen is it'll go back inside and line up. Okay? Make sense, guys? We're good? Okay, let's move on. Okay, now I got to do a little magic trick here. Hold on a second. Okay, I will end the show. Shrink that. Let me expand it first. Good. And introduce you to...
The CT6 traction splint is a significant investment by the QAS in patient care. The Donway has been a long doyen of the service and does really well for the last 10 years or so.
Can you hear
But as technology has improved, it's important that the QAS moves with that technology. The CT6 offers the following advantages. It's light, it's small, it's easy to use, it can be used on paediatric patients. It actually can be used for patients with bilateral femoral fractures, which we haven't been able to do with the Donways previously. And most importantly, it can also be applied to patients who have a pelvic splint in situ. It's important to recognise that the application of a traction splint to femoral fractures is a very important part of hemorrhage control and analgesia. So these are priority for patients who are suffering significant trauma and have a femoral fracture. We do understand that a number of our patients have potentially a significant pelvic fracture as well as a femoral fracture. With the new CT6 splint, we can apply the pelvic binder firstly, and then apply the CT6 traction splint to our potential femoral fracture as well. It's important to do it in that order. Remembering, you're more likely to bleed to death from a fractured pelvis initially than you are from a femur. But addressing the femoral fracture is very important because it does reduce long-term morbidity and mortality with that condition, especially when applied early. So it is a priority of care. Over the years, paramedics have asked me, what type of splint do we use for particular fractures of the lower limb? It's important to recognise that the CT6 is not to be used for neck or femur fractures. The use of the CT6 is for shaft fractures of the femur, not involving the knee joint. For fractures of the knee joint or the tibia or ankle, we use the vacuum splints that are supplied by the ambulance service. A long leg vacuum splint is to be used for all fractures of the knee or the proximal 2/3 of the tibia. For fractures involving the distal 1/3 of the tibia and the ankle, a short leg vacuum splint with the leg placed into anatomical position is the way to go. By now, you will have read the Lassen directive on the CT6 splint. I know you will have committed it to memory. From here, you're watching this video, which will demonstrate the application of the splint. So the next thing you do is, with a work colleague, is to apply a splint to each other and get to know the workings of the splint, so that you can adequately perform it in an operational environment. The next thing to do is to go to LMS and complete the self-sign-off. From there, you're free to use the CT6, and it will be a very important part of your patient care.
The CT6 is a traction splint that aligns and immobilises femoral fractures. The splint reduces muscle spasms, pain, and helps prevent blood loss and any further damage to anatomical structures. The splint comes complete in this small kit bag, making it easy to store and transport. The CT6 uses this adjustable ischial strap around the upper thigh. This is the ankle hitch, and it consists of the ankle strap, the foot strap, and the safety clip, and it is used to hold the foot in place while traction is applied. This is the splint assembly, and it comprises of a multi-link tubular frame, leg straps, and the tension-adjusting block and line mechanism. The extension strap is used to lengthen the upper thigh strap for larger patients. We will now demonstrate the use of the CT6 traction leg splint. Step 1. Assess the injury. Expose the affected limb. And assess the limb for distal perfusion. Step 2. Remove the splint from the bag. Release the external bag straps and remove the splint from the bag. Step 3. Assembly. As the splint is removed from the bag, hold it at shoulder height and shake it up and down, allowing the tubes to hang and intersect. Now manually connect any unlinked sections. Step 4. Sizing. To gauge the correct length, place the unit alongside the uninjured leg. Now the ischial cap should align with the top of the patient's pelvic crest, with the ankle hitch end approximately 15 centimetres beyond the bottom of the patient's foot. Step 5. Adjust length. If the splint appears to be too short or too long, tube sections should be added or removed as necessary for correct sizing. Now here, the correct size is accomplished by removing the ischial cap and one piece of tubing folded back. Now secure any disconnected sections with the ischial cap. Step 6. Attach strap. Move the splint alongside the injured leg and align 2 straps above the knee and 2 straps below the knee. Now take care not to strap over the injury or over the knee. Unclip one end of the strap from the ischial cap and place the strap under the patient's upper inner thigh. Reattach the appropriate end to the ischial cap and attach the clip. Now ensure the buckle is on top of the patient's thigh so adjustments can be made, and then tighten the buckle strap. Step 7. Attach ankle hitch. Unwrap the Velcro strap and align the hitch with the patient's leg. Now gently lift the patient's foot enough to allow the hitch to be slid under the patient's ankle. The thicker strap should be positioned to be wrapped around the patient's ankle directly above the foot. The second strap should run beneath the patient's foot and align equally on opposite sides of the patient's ankle. Tighten the strap to minimize the distance between itself and the bottom of the patient's foot. Step 8. Traction. Pull the line to apply a minimum amount of traction so that the splint is resting in its appropriate position. Now this can be achieved by pulling the loose end of the line exiting the purchase block and line mechanism below the patient's foot. Now lift the line up into the V-jam cleat to achieve tension, and the V-jam cleat will hold the line secure. Step 9. Securing and applying traction. The first strap is placed around the upper inner thigh, ideally above the fracture. The second strap is wrapped above the knee, ideally below the fracture. The third strap is placed below the knee, and the fourth strap is placed directly above the ankle hitch. Now, apply traction as required by readjusting the tension until the patient's comfort is achieved.
Applying traction with the CT6 splint is a little different to what we're used to with the Donway. As you know, with the Donway, we have a nice gauge that gives us a reference point when we have enough traction applied. Now with the CT6, it's a little different. What you'll have to rely on is actually clinical information that you're seeing when you're actually applying the traction. So when you're applying the traction with the pulley system, you should see the leg lengthen, and really what you should be aiming for is getting the length of the injured leg to the same length as the uninjured leg. Now, in the unlikely event that it's a bilateral femoral shaft fracture, what you'll have to do is just watch the legs. Now, you'll actually see the effect of traction on the thigh area when you pull the traction on, and that will give you good feedback about how much traction you have applied. But remember, traction is very, very important. And while we're thinking about traction, you may actually have a compound or an open fracture. And remember, it's very important that we liberally wash that wound. And that is with at least a litre of normal saline, because what we don't want to do is see that bone retract into the leg or thigh cavity covered in dirt. So it's very, very important that we give it a good wash before traction is applied.
Lift the line and re-lock into the V-jam cleat. Step 10, final adjustments. Tuck any excess line under the leg strap. Now check the splint is correctly in place and achieving the desired results, and make any final adjustments. The traction pulley can be shortened if needed. Firstly, the upper thigh strap can be loosened. Pull on the loose line and reapply traction as needed. Tuck any excess line under the leg strap. The CT6 can be applied after the pelvic binder is in place. The CT6 can be applied to bilateral femoral shaft fractures, and the CT6 can be applied to children with fractured femurs. Repackaging the CT6. Reattach the ischial strap to the splint. Re-roll the ankle strap and secure it with Velcro. Now ensure the straps are straight and none of them are hanging over the connected segments. Now pull each segment and fold it back on top of itself until you get to a tight little bundle. Now pull the ankle hitch through the unit and roll the unit. Best results are achieved when the straps are stacked in pairs and the ankle hitch is free of the roll. Now place the CT6 back into the bag, ankle hitch side first for easy deployment. And that covers it for the CT6 traction leg splint. Now make sure you get your hands on one and have a play prior to deployment.
All right. Okay, guys, so that is done, that's used by class, right? Our brothers and sisters to the north as well. Okay, and they have slightly different rules about using it than we do, but it's the same basic principle. Okay, so at this point, are there any questions that I can answer for here? No? Good, because we're going to demonstrate. All right. So can I ask David and Alicia to give me a hand? Yeah.
David looks like you need one.
I need what? A splint.
Dave.
Okay.
Remember yesterday. Okay. So we will mark. Dave. Alicia wants you to move up a bit. Use that broken leg.
Yeah.
Okay. See you safe? And PDE? Okay, good. How you doing, sir? You're doing good. I don't know. It looks like you got a broken femur here, and you must be in a lot of pain.
Yes.
Okay. So we have a traction splint that we can put on that will take